The truth is we don't know what the right amount is. It's really an area that we need to investigate more. But again, just a little bit of sunlight, I think, is all that's needed to help stimulate some of the pigment cells to come back.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I've been doing pretty well, but, I'm always thinking about something. And today I was thinking more and more about, what about pigmented disorders of the skin? What do you think?
Well, I think that's a weird way to start your day thinking about this, but I accept the challenge. I do think we see in our clinic a lot of folks with pigmentary disorders, probably the prototypical one being vitiligo, that really impacts our patients significantly. I think it's also a prototypical disease for so many other reasons. It's immunologic base, just the idea of disease on the outside that often have so many misconceptions and cultural implication. It's just a fascinating skin condition and a medical condition in general. So today we thought we will dive into it a little bit, but we really need an expert. And I think today, you'll introduce our mystery guest, but today I think we have a special treat.
Oh yeah, we do. We've got an international expert. We've got Dr. David Rosmarin, and he is chair at Indiana University, but I have seen him over the years just talk a lot about different sort of clinical trials. He's an expert clinical trialist as well, and he knows this data in and out. And, without having to go on and on about his bio, we'll let him introduce a little bit of himself. But David, welcome to the podcast. We're super excited to talk to you.
Thank you. I'm excited to be here as well.
And now, before you get into it, I just want to also mention that this podcast is supported by AbbVie Medical, and we appreciate the support so that we can really put on programs like this. But David, before we get into things, can you please tell us a little bit about what got you interested in this area of vitiligo and in dermatology, just to give us a little background into what really drives you?
Yeah, so the way I got involved with vitiligo was seeing some patients and realizing, this is really challenging to treat, and topical steroids or calcineurin inhibitors weren't the most wonderful treatments we have. They can help some, but there are a lot who weren't improving with those agents. And when I was thinking about it, I was reading about vitiligo in a DermPath journal, that it can sometimes be an interface dermatitis. And oftentimes interface dermatitis are Th1 dominated. And so it had me questioning, especially with the new data on use of JAK inhibitors for alopecia areata, that they're good at suppressing interferon gamma and the Th1 pathway. Could that potentially help patients with vitiligo? And then I reached out to different companies to see, could we trial a JAK inhibitor in this disease? And that's what got me started back in 2013, 2014.
Wow, so you've been doing this a while, and I think this kind of line of thinking is really fascinating to me, because when I see leaders in our field, and probably outside of dermatology, it's that ability to translate the medical knowledge to the current therapeutics that are emerging that really brings the cutting edge innovation. And you've been doing this for over 10 years now, when JAK inhibition is kind of still considered a new kid on the block. Perhaps for our more junior listeners and just the general audience, can you explain how you become a clinical trialist? I think it's a pathway that is not that is known, but not very clear how people get to that. And I've been getting questions from residents and other trainees on wanting to be a clinical trialist. I mean, you have extraordinary success. I mean, first author publication in mega journals. How did you get to that path?
Honestly, I owe it to mentorship. And when I first started residency in 2006, Alice Gottlieb was the chair, and she is a well-known clinical trialist and got me involved even during residency. Now, it's harder for residents to get involved now than it was, but I was helping as a sub-investigator back in training, and that led me down the pathway of doing clinical trials and asking interesting questions. But I think mentorship is really key. So for those who ask me, how do I get involved in clinical trials? Well, I think it is helpful to establish mentorship with someone out there. There are also different ways to educate yourself as well. For instance, the AAD now has a whole course on clinical trials, which I think is really well done. I give one of the lessons on alopecia areata, but there are many expert clinical trialists that give fantastic lectures, and that's available to really all our dermatology colleagues via the AAD website.
Excellent. Well, folks, you heard it here. You just got to surround yourself with good people. And that's what I did. I found Raja, and the rest is history. All right, let's dive into vitiligo. I mentioned in my intro that this is a disease that really burdens our patients, but I think one of the key thing in vitiligo specifically is a lot of the common misconceptions that folks have in the community about this disease. Perhaps, David, you can go over some of those common ones. How do you then guide your patients, educate them, coach them on how to handle those misconceptions?
Yeah. So there are misconceptions that happen for people who don't have vitiligo, for some of the people who do have vitiligo, and then also for even some providers have some misconceptions as well regarding the disease state.
That's very true. Yeah.
So we can break that down. One of the things that I commonly hear from patients is they have concerns that other people think they're contagious. And they'll describe stories where they're in the supermarket and the cashier doesn't want to touch them or take their money directly. They ask them to put their money down on the belt instead of, or other people don't want to shake their hand. And so that is one misconception that out there is being contagious. And I think that there's work to be done in how do we educate the broader community that's not that aren't vitiligo patients, that people who have that disease are not contagious. Another one that often bothers me with the payers are that this is just a cosmetic condition. It's not a big deal. Nobody dies from this. And what I would say to that is that it's an autoimmune condition. It's a medical condition. And if it affects people, well, then it's our job as providers to try to help make people better. The other thing that I hear from patients is that they're worried that it's an inherited disease and it's genetic. And there is a genetic component, so that if a person has vitiligo, the chances of their child having vitiligo is 6-fold higher, so around 4% rather than about 0.5% in the general public. So chances are that that person won't have a child that has vitiligo, but it is an elevated risk. So there is some small genetic component. A lot of people think they did something wrong to get the vitiligo, and that's just not true. And they should be rest assured that it really wasn't caused by their diet or something else. There can be an inciting event such as stress, but we don't think that they really did something to cause their vitiligo. And in terms of what are some misconceptions out there for providers, for us dermatologists, well, sometimes people think they're at higher risk for skin cancer. And it's actually the opposite. Vitiligo patients are at lower risk for skin cancer. Now, we often do tell people with vitiligo they should avoid the sunlight, and that's for a couple reasons. One is when they get sunlight, it enhances the contrast of the normal skin, so the vitiligo becomes more noticeable. And two, vitiligo patients can get burned from the sun. But actually, our studies show that people with vitiligo are at lower risk for both non-melanoma and melanoma. skin cancers. So I think that that's helpful to know. And when we're treating people with vitiligo, actually a little sunlight can be helpful to stimulate the pigment cells to come back. So I think those are some of the misconceptions that we see from our payers, from our patients, from people who don't have vitiligo. And those are still persistent in the community.
Thank you for taking us through that, because I think these misconceptions still persist. I really appreciate a lot of these points, including the sun protection, sunlight exposure portion of things, which kind of begs the question to really address, what do we know about the underlying pathogenesis, and what have we learned in the more recent years? Can you take us through the journey on what do we know and where are we headed?
Yeah. So when I first started on this journey, I remember reading a review article which had only a very small fraction of a section on the immunopathogenesis. And there was a lot more on oxidative stress, on diet, and on other aspects of health. But now we realize that fundamentally, vitiligo is an autoimmune disease. Elevated levels of interferon gamma are leading our CD8 positive T cells to attack the melanocytes. And because interferon gamma signals through JAK1 and JAK2, through the JAK-STAT pathway, those have become an attractive target for treating patients with vitiligo. But what's also emerging is that even though it only takes an overactive immune system to cause vitiligo and create these white patches, it's not enough to just suppress the immune system to get the pigment cells back. So one of the things that that's really important is we think about calming the immune system down, but as a second step, how can we stimulate those pigment cells to repopulate the skin? So I think both of those aspects are really, really important in terms of the pathogenesis.
I really appreciate you making that point, which is, we've got such a focus on bringing the inflammation down, which is very true, but then stimulating that pigment to also come back kind of gives us a little bit more to work with, doesn't it? So I am curious, when you talk from this sort of perspective, what kind of disease course management options are we looking at? I mean, obviously we have some pharmaceuticals, but what role does phototherapy play in this? What role does pharmaceuticals play in this? Maybe take us through how you might evaluate a patient. What do you look for in your patient? And then how do you approach treatment?
Yeah. So, first, in terms of stimulating those pigment cells, I'm thinking about, and I almost always offer phototherapy, or at the very least natural sunlight to patients to try to stimulate those pigment cells. And one of the things that people don't realize is actually JAK inhibitors can stimulate pigment cells as well. They stimulate melanocytes, they stimulate c-KIT, MIT-F, LEF1. So they have a dual function when I'm treating patients with vitiligo. Now, you also commented, what happens when I first see a patient? Well, the first thing I'm asking is that patient progressive or stable? Is that patient developing new lesions or not? And how do I tell that? Well, they're sometimes by history, but often by some physical exam findings. So if the patients have trichrome vitiligo, 3 colors, the normal skin, the white patches, and a color in between, that indicates that they have activity. If they have confetti lesions, these 1 to 5 millimeter well-demarcated circular macules, that also indicates activity. The Kebner phenomena and inflammatory vitiligo are much less common, but also are 2 other physical signs that indicate this patient has more active disease. And in that case, my first goal is let me stabilize the patient. It's a lot easier for me to stabilize them than to repigment them. And the way we can do that is with oral steroids. We give dexamethasone 2.5 milligrams on 2 consecutive days for about 12 weeks. And that works in about 90% or more of patients. If it doesn't, then I just redo the course, but upping the dose to about 5 milligrams of dexamethasone. And then in terms of once the patient stabilized, I'm usually thinking about, well, how can I then help repigment the patient? And to do that, I'm either giving a topical steroid, calcineurin inhibitor, a JAK inhibitor, either topically or orally. Now, orally, they're currently off-label. And then I often offer phototherapy with concomitantly for those patients. However, many patients, due to convenience and copays, usually opt for just the steroid, calcineurin inhibitor, or JAK inhibitor alone. And if that doesn't work, then they're often will add in a JAK phototherapy subsequently.
I love that we're getting some clinical pearls here, and just wanted to expand on what you were saying, because there was a little piece in there that I think can be really, really helpful to all of us that are listening in, which is that when you're looking at a patient, you're looking at whether they're progressive or stable. And if you can also give us a little bit extra on, are you looking at the body surface area when you're considering progressive? My understanding is that you're not. You're looking to see, are these patterns present? But how does body surface area come into play, or does it, when you're considering progressive versus not?
Yeah, so I don't usually consider body surface area when I'm thinking about the progressive or stable concept, but it does matter in terms of choosing the right treatment. For example, if a patient has involvement of areas that are hard to treat topically or a large body surface area, then I'm more apt to think about a systemic agent for the patient. And that could be just phototherapy. It could be an oral JAK, which is off-label. So that's where body surface area, I think, plays a larger role.
Yeah, David, I want to jump in here with a couple of questions. This is so fascinating, I think, because one of the more common misconceptions about vitiligo is that there are no treatments, but clearly you and others, and I know I in my clinic as well, we have plenty of ways to treat it. It's still not the perfect scenario, but we definitely have treatment. So thank you for guiding us through that. As you were seeing the patient for the first time, you kind of highlighted some of the things you're looking at the physical exam, but how do you counsel them on what to expect on the natural progression of the disease? And maybe you mentioned also that you're looking in the skin, you're seeing some changes that tell you something. In other words, like a biomarker, but do we have any laboratory or other more objective-based biomarker than just a physical exam? So two-part question, but how do you counsel them, and a little bit about new biomarkers?
Yeah. So I'll answer the one about biomarkers first. And it's unfortunate that we don't have standard biomarkers that we use. It's really, we're reliant on our physical exam skills right now. We do know that levels of CXCL10 are associated with higher body surface area of involvement, and that's associated with, again, patients having significant disease. However, it doesn't determine prognosis. Interestingly, patients who are type 2 skewed, and this is shared with alopecia areata, they tend to have a better prognosis. So if a patient has eczema, that's a positive feature for patients being more likely to respond. And we see the same in AA. The other thing that I'm looking out for is leukotrichia. The white hairs are an indication of a poor prognosis. So I mentioned the importance of how do we get those pigment cells to come back? Well, we think that those white hairs are indicative that patients may lack the reserves for the pigment cells to come back, because the pigment comes back usually from the follicle. Now, the other thing is that it really matters where the involvement is. If patients have facial involvement, I'm actually very optimistic that we can get patients better. However, if they have the fingertip involvement, other glabrous areas like the nipples, the tips of the genitals, the lips, those areas almost never repigment. And I counsel patients that it's highly unlikely we'll get the pigment back. It may not be worth it to even treat those patients, because I want to set appropriate expectations. But if they've head and neck involvement, I'm much more optimistic and can tell them that we have a better prognosis. Now, why is the head and neck easier to repigment? Well, it's denser follicularly, and that's what seems to correlate most. Now, unlike alopecia areata, it doesn't matter how long people have had their disease for. So if people have had vitiligo for over 30 years or just 2 years, they still have about the same prognosis, whether they have a large body surface area involved or a small localized spot. they have a similar prognosis as well for responding to treatment. And that's very different from alopecia areata, where if people have the hair loss, their episode for more than 8 years, or if they have alopecia totalis, so severe disease, they're much less likely to respond. That's one difference. We don't see that for vitiligo.
Wow, that's awesome, folks. You heard it here. In 2025, still, there's no substitution to a very good physical exam by a board-certified dermatologist. I mean, there isn't. And this is fascinating. You got to look everywhere: the hair, trichome, all this great stuff. David, I wanted to just make one clarification because it may be important to some patients who are listening to us. You mentioned sunlight exposure, which I don't want folks going out there and starting to bake in the sun. So what's the dosing on this? How do you dose it and explain it in plain language to your patients?
Yeah, great. Because we certainly don't want people getting burnt. We also don't want patients to bake in the sun. What we just are talking about maybe a couple times a week for 10 minutes or less of natural sunlight. And the truth is, we don't know what the right amount is. It's really an area that we need to investigate more. But again, just a little bit of sunlight, I think, is all that's needed to help stimulate some of the pigment cells to come back and work synergistically with our other treatments that calm the immune system down.
Hadar, I also wanted to jump in and say, with phototherapy, just because we do a lot of it, you can also do home phototherapy that has become easier and easier to get now. It historically used to be a little bit harder, but it's become easier to get home phototherapy if it becomes tough for people to get to the clinic, or if you're looking at having some standardized dosing.
That's absolutely right. There are home phototherapy you can get not only through phototherapy companies, but also just on Amazon. And I know my friends in Henry Ford always say that the devices that they recommend on Amazon actually work similarly well to those expensive devices that we are using in the office, or we may purchase from a dedicated company. So that's a great option for patients as well.
So, David, you really took us nicely through the exam and kind of implication for counseling patients. When they come back in the follow-up, what are you looking for? So you started certain therapy. What are you looking for to make sure that now you stabilize the disease? And then what does that mean for the next step in therapy?
Yeah. So it's very hard to remember exactly how a patient was when I last saw them.
What? You mean you don't remember all the 50,000 visits you have a year?
That's right. And so I can't emphasize the importance of taking pictures. It really helps. Now, you don't have to take pictures of every lesion, but taking pictures of certain spots is just really helpful. And patients will often say, I'm not getting any better, when they really are. And it's very motivating for them to see the difference in pictures. And sometimes patients think they're getting better when they're really not. So pictures are objective, and it's much easier. It's very hard to document how patients are doing in just our notes. So I really think that that's important for you or your MA to take pictures of patients and to share those together to see how the patient's doing. And I usually see patients back about 6 months later, because vitiligo repigmentation takes time. It's not a quick process. And I counsel patients that don't look in the mirror every day to see if it's starting to work, because it's going to take some time. You may not see anything until around the 6-month mark. And even if it's just a few follicular pigmentation dots, that's okay. It can take years to repigment, and patients have to be prepared for that journey. It really is a journey.
Oh, I second, third, fourth, and fifth your recommendation about pictures. I can't say this enough. I mean, in other diseases as well, but especially pigmentary disorders and vitiligo, forget the objective. It's just that what you mentioned, the energy it gives patients to actually see that, because they're kind of watching paint dry every day. To them, they don't notice the difference. But if you, after a few months, show them that, you can visibly see that on them. They're really getting invigorated. Do you use Woods lamp still?
Yeah, Woods lamp is a key tool that we have. So, especially for patients who are fair skinned, skin types 1 through 3, it's very helpful. Oftentimes, at the first visit, when I'm using a Woods lamp, um, patients may not realize how extensive their disease is, and that's when they get very emotional, and that's when they need the tissues. There's an interesting study that just came out of the EADV on subclinical vitiligo that many patients have the subclinical disease, and what's defined as subclinical is you can only see on Woods lamp, you can't see with the naked eye. Now, it was a study done out of, I believe, Denmark in Europe, so they didn't have many skin of color patients like we have in the United States. So again, that's something that's just really true. You really need a Woods lamp for these patients. It doesn't add much extra time. It's really an important part of our toolkit to assess how extensive patients' disease are.
And that's great. I wanted to ask you, David, about melanocyte transfer and maybe other procedures. We mentioned light, which I guess technically is a procedure, but are there any surgical procedures like melanocyte transfer that are really viable that patients can opt for?
Yeah. So melanocyte transfer is not as commonly done in the United States as outside of the U.S. It's very commonly done in India, in the Middle East. However, one of the challenges is it's really not reimbursed in the United States, so it's out of pocket for patients. And there are different ways to do it. So some patients will do melanocyte transfer with a punch tool. Others will have a special device to create blisters and then suck out the melanocytes that way. But there are remaining challenges, and there are some companies that are trying to develop devices that can help us. So ReCell, for example, has a device that was recently approved by the FDA for melanocyte transfer in the office. However, again, the challenges are really around coverage and paying for it. And I am hopeful, though, that we'll have better treatments as well going forward. Melanocyte transfer is often a really good treatment for patients who have segmental vitiligo, because segmental vitiligo is very localized to one part of the body, and it's stable for the rest of people's life. Non-segmental vitiligo can get worse at any point in time, and so it's a little less conducive for those patients.
Yeah, and I wanted to, now that you're kind of talking about some advanced therapies and looking at, I'd be curious to understand, how do you personalize your approach to vitiligo treatment? And maybe embedded in there, can you talk about, non-segmental is the vast majority of vitiligo, correct? And how do you approach the treatments when you're looking at your patients? And how do you address comorbidities as part of that?
So that's absolutely right. When we say vitiligo, we really mean non-segmental vitiligo, and that about 85% of patients have non-segmental type. Segmental type's a little bit more common in a pediatric patient, has a poor prognosis because there's often more leukotrichia. It rapidly progresses over 6 months to 2 years, and then stabilizes for the rest of somebody's life. So when we're talking about vitiligo, we're really here talking about non-segmental vitiligo, but they're both autoimmune. And because it's autoimmune, the most common comorbidity is autoimmune thyroid disease, either hyper or hypothyroidism. Now, I personally will check a screening TSH. Some people will also check thyroid antibodies as well. I don't routinely screen for other autoimmune conditions, which patients are at an increased risk for, but they're still not so common. Up to 20-25% of patients can have autoimmune thyroid disease, though. So again, a screening TSH can be helpful. Now, I always say we treat patients, not disease. So it really depends on what the patient is looking for. Sometimes patients just want their disease stabilized, and that's what we do. If patients have fingertip involvement and they're not going to be happy unless they get their fingertip pigment back, well, then we have that conversation that maybe it's not worth it to treat them. However, sometimes patients that have facial involvement, it's really bothering them, and they don't have any leukotrichia, and that has a really good prognosis. And we tell them it may take 2 to 3 years, but there's a good chance we can get a significant amount of their pigment back. And usually if patients can get 50 to 75% of their pigment back on their face, they view that as a very good outcome.
Thank you. These are such excellent pointers. I wanted to talk about treating early and the importance of doing that, because I think some dermatologists may be hesitant to kind of, take out the quote unquote big guns, do systemic therapies and such. What is your thinking about that? Is there a window of opportunity there that we can make a difference? How do you approach that concept?
Yeah, so it really matters to treat some diseases early, like we're learning in alopecia areata. The earlier you treat patients who have their disease, they have better prognoses. That's not true for vitiligo, but what really matters is if patients are worsening, it's a lot easier for me to stabilize them than to wait for them to depigment further and then try to repigment. And because repigmentation is slow, it takes a long time. So from that perspective, I really am, I need to be pretty aggressive for patients, especially if they're on the fence, if they have active disease. I don't want them to leave the office if they're worsening. I want them to get that course of dexamethasone so that we at least stabilize. Once they're stabilized, if they need time to think about whether they want to start a treatment for repigmenting, then they have some time to wait and think about and what may be their best option. Maybe it's not the right time for them to undergo phototherapy, especially if they have vacations coming up, but if they're very busy at work. So I think that, again, we want to treat patients, not the disease, but I think it's important for us to be very aggressive at stabilizing the disease so patients aren't worsening, because it can be really challenging to repigment. Once patients get depigmented in the fingertips, very little we can do to get the pigment back.
Wow, David, this was a real tour de force. I can't believe in such a short amount of time we covered so much ground. We talked about the misconception and the pathogenesis and treatment and examining patients and guiding patients through this. And I think any of our listeners are really grateful at this point to pick up this episode. I know I learned a lot, and I feel like all our listeners as well. So with that, I want to thank you. We can stop here, and I want to thank you, although there's so much more to talk about in vitiligo, so happy to see you in a next episode coming anytime soon. Thank you very much.
Thank you, Raja and Hadar.
Thank you.
Thank you for tuning in to the LearnSkin podcast. We hope you enjoyed today's episode and found valuable insights to take away with you.
And before you go, we'd love to ask for your support in helping us reach even more listeners just like you. Leaving a review on your favorite podcast platform not only helps us improve, but it also boosts our visibility and helps others discover our show.
So, if you found this episode helpful, inspiring, or thought-provoking, please take a moment to leave a review and share your thoughts. Your feedback means the world to us, and it truly helps us grow.
Thank you again for being a part of this journey with us. And until next time, stay curious.